Good evening. Thank you for tuning in to Face to Face. I'm your host, Dennis Ward. Our guest this week on Face to Face is Dr. Jim Simm. Dr. Simm is a Winnipeg psychiatrist who specializes in the assessment and treatment of patients with addictions. He has close to 200 methadone patients under his care and often provides expert testimony on addictions to the courts. He's also an associate professor with the University of Manitoba and is also known as an expert when it comes to opioids and addiction. Dr. Simm, appreciate you taking the time to join us here today.
Pleasure to be here, Dennis.
I'd like to start with the current fentanyl crisis and your thoughts on how bad the problem really is.
The actual numbers of people that we see presenting for treatment for opioid use disorder or opioid addiction hasn't increased. The big thing is the lethality of fentanyl. And some of the analogs of fentanyl, like carfentanil, the difference is like 2 grains of salt will kill you and 1 grain of salt will get you high. So frankly, although the numbers haven't gone up, more people are dying.
And so if we're not seeing a big spike in the number of users, why are we hearing so much about it?
Well, frankly, the deaths. And it's a horrible thing, and we're hearing more about it because of the number of deaths.
And are you aware of many here in the city, in Winnipeg and Manitoba?
Well, the numbers have gone up. Between 2010 and 2012, there was about 18 deaths out of 168 deaths of opioids were due to fentanyl. And just in last year alone, there was 29 deaths. And early on in this year, we've already heard of a number of deaths of either fentanyl or carfentanil. So it's going up, and the worry is that the epidemics that we're seeing in BC and Alberta are going to spread here, and the situation's going to get even worse.
We've heard a lot about it here in Manitoba. You think this isn't, I guess, yet the spike here in this province as we've seen in other provinces?
That's the big concern, that things are going to get worse.
And what would lead you to believe that things would?
The OxyContin epidemic, which started around 2000, started out east and out west and slowly spread, and it slowly got worse. So I suspect the pattern will be much the same with fentanyl, that it will slowly spread here.
We're hearing a lot, obviously, about fentanyl in the news because of the deaths and the numerous deaths that are occurring here in this province of Manitoba and BC, Alberta. But you say that you've said that the fentanyl is a bit of a blip on the opioid crisis that's been going on for some time.
It's been getting much worse since the late 1990s, and that seems to be directly connected with excess prescription of OxyContin. When I first started working in this field, there was about 25 patients in Manitoba on methadone, which is a treatment for opioid use disorder. Now there's over 1,200 patients in Manitoba on either methadone or Suboxone, and that number's been pretty consistent over the last few years. So the fentanyl, there's not more people using it, but people die a lot quicker.
What led to the prevalence of opioid prescriptions when you say there was a couple of hundred back then and now more than 1,000?
Well, just 25 back then. What led to the prevalence? There was a medication called OxyContin, which I think most people have heard of. It was marketed to doctors that this was an absolutely safe medication to use in the treatment of chronic pain. All doctors see patients with chronic pain. They were quite happy to hear there was this medication that could be used and it was completely safe. It was very heavily marketed in the States. In Canada, doctors were given educational events that stated, prescribe this, you can go as high as you want. Unfortunately, the effects of OxyContin soon became apparent that people were getting addicted to this medication, people were using it in ways it wasn't meant to, they were snorting the medication, they were using it intravenously. And regulatory agencies and the pharmaceutical companies were slow to react to that. Purdue Pharmaceuticals in the States actually had a $600 million US lawsuit passed against them because of what was felt to be unscrupulous practices. And we were slow in the medical field, I think, to realize the mistakes of overprescribing this medication. One expert in the field described it as the worst man-made epidemic in the history of medicine.
Now, was this, in the 90s, OxyContin was given approval by Health Canada to be used for things like headaches, severe headaches and pains like that. What, what led to getting that approval and prescribing it for something that people used to take an aspirin for?
The studies that were cited to Health Canada were short-term studies, and they also used information that really wasn't meant to justify the prescription of opioids for chronic, it's called non-cancer pain, but things like back pain, headaches, as you mentioned, just the aches and pains of everyday life. It was approved by Health Canada. There was no limits on the amount prescribed, and it was prescribed in very large amounts. And the medical profession, I think, was slow to recognize how devastating it had been.
Do you think something like OxyContin should have ever been prescribed for things like headaches, pains that you might have on a regular basis?
Rarely. I won't say never, but like you mentioned, things like aspirin or even counseling for tension headaches. And if all of those had been trialed and things were severe, very careful prescribing with relatively low dose, looking for signs of addiction, but it shouldn't have been first line, and it shouldn't have been prescribed in the amounts that it was. And it's easy to say 20 years later that we made this mistake, but at the time, I think most doctors thought they were doing the right thing.
Are we still feeling the effects 20 years later after realizing the mistake?
Oh, yeah. I think the regulatory agencies and some doctors thought, well, the problem was just OxyContin, so they deregulated OxyContin, meaning it wasn't paid for by governments anymore, and they came up with a form that was much harder to abuse called OxyNeil. Well, people simply changed what they were using. There's medications called Dilaudid or fentanyl patches that people just started using instead. So it was just shifting to a different drug that had the same effect. So it wasn't just OxyContin in particular that was the problem. It was the fact that this drug acts on the opioid receptors of the brain, gives you a high, makes you forget about your problems, but soon you're addicted to it, and it's really hard to stop.
You mentioned the lawsuit against the pharmaceutical company, but I mean, were there others to maybe blame for this? Government regulators, doctors who maybe didn't know what the effects were going to be on their patients?
Yes, the blame can be spread around. I personally, speaking just for myself, would put the major part of the blame on pharmaceutical companies looking to increase their profits, but doctors that were slow to react to the crisis and regulatory agencies played their part too.
The abuse of OxyContin became a real problem in many First Nations communities. The Anishinaabe Nation in Northern Ontario had to declare a prescription drug abuse state of emergency. Do you think that that crisis was handled properly, and does it continue today?
In November 2009, it was declared a state of emergency. It took a few years, I think, before it was recognized and proper funding was put in place. So the timing wasn't perfect. Although there were some programs put in place, one of the most successful programs was there's a medication called Suboxone that treats opioid addiction. And I think 46 of the First Nations have access to these programs, and there are programs set up not only with the medication, but also counseling within communities, intensive day programs, culturally appropriate day programs, and they've had great success with that. There's a Dr. Folk in Manitoba and a number of other doctors that go out to that area. And some of the success rates they had with Suboxone and with intensive day programs were actually quite amazing.
We're speaking here with opioid expert Dr. Jim Simm. We'll have more with Dr. Simm on Face to Face coming up after a short break.
If a story is uncomfortable, would you change it? No, you wouldn't, because there is no power in holding back. Stories have the power to change lives, so true storytellers uncover every side of hunger, of families, water, shelter, and health. So we're going to tell your stories every day until issues transform and our communities transform with them.
Welcome back to Face to Face. Our guest is Dr. Jim Simm, an expert on opioids. Dr. Simm, we're hearing a lot about fentanyl in cities like Winnipeg, Vancouver, and Alberta, bigger cities, but has it begun to hit First Nation communities?
In Alberta, the Stoney Nakoda Nations have had a real serious problem with fentanyl. The Blood Tribe in Alberta has had serious problems. In Manitoba, not so much. Although I suspect it may be just a matter of time. Fentanyl, the black market fentanyl that's available anyways, is very easily transported, small amounts. It could easily start to hit the local First Nations communities, but from what I've heard, it isn't there yet.
You know, Blood Tribe is well documented the number of problems they had there, numerous deaths. Do you think it hit there? It almost looks as though it hit there first before it started getting on the radar in some of these bigger cities.
Yeah, I'm not sure of the exact timeline. It's available in Alberta. So I think the fact that it's available in cities near there, it's easily transported, both the Blood Tribe and the Stoney Nakoda Nations. So as I said, I don't know the exact timeline. I know BC and Alberta have been the worst hit with the fentanyl crisis so far.
Is there a concern that fentanyl will replace other prescription drugs that are being abused in First Nation communities?
There's a good chance of that. The availability of the substance sort of determines how many people are going to abuse it, and the more easily it's available, the more likely it is to be abused. And doctors now, most doctors are aware of the dangers of prescribing large amounts of OxyContin, hydromorph, so there'll be less prescription drugs on the market. The fentanyl is available, as you viewers may have heard, black market through either China or Mexico, so it may be replacing a lot of the prescription opioids.
Dr. Simm, you're a psychiatrist. What are some of the reasons, you know, that you are hearing from people with these addiction problems for reasons for using these drugs?
It's actually pretty simple. It feels good and it works to kill emotional pain. And it has hit First Nations communities really bad, but they're not alone. The opioid crisis in the States seemed to hit a lot of middle-class homes. There's been other opioid epidemics throughout history, Vietnam-era veterans. So it's just basically people use it, it feels good, and they try to stop taking it. They feel terrible, their symptoms come back. So the use keeps increasing. It's hard to tie down to any one factor.
Can you describe to us, you know, what day-to-day living conditions for somebody with this addiction is like?
For a lot of my patients, it becomes overwhelming. It takes over their entire life. People aren't able to work anymore. They're not able to take care of their children. their whole day revolves around trying to get the substance or recovering from the use of the substance. I tell residents that often there's only 3 ways people can sustain this habit, and that's to steal, peel, or deal, which basically means they have to indulge in crime, they have to engage in prostitution, or they have to deal themselves to support their habits.
So obviously, you know, this addiction leads to numerous other societal problems that we see.
Yes, crime, child care involvement, suicide. It devastates communities.
You're involved with telehealth. How difficult is, you know, providing proper coverage, proper services to, you know, some of these remote First Nation communities?
Telehealth is adequate. You know, we're able to interview people. The reception's reasonably good most of the time. They can see me, I can see them, we can hear each other. It's not as good as being face-to-face, but in the absence of anything else, it's adequate. If I just have a minute, usually the procedure is that we'll get a consult from a remote community. We'll do the initial interview via telehealth, get some sense of what the problem is, sort of arrange treatment, and then often somebody will come to Winnipeg for initial hospital treatment and then arrange community treatment afterwards. So it's adequate. It's not perfect.
What could be done to provide better resources?
I think the first things I would like to see is the availability of Suboxone treatment in Manitoba. It's had great success in Northern Ontario, in a lot of the communities there. Crime rates down 60%, child and family service involvement down 60%, suicides down by a huge amount, attendance at school for children up. And that's something we're not able to provide in Manitoba. So that if I could pick one thing, Dennis, that would be the one thing that I would pick.
And what's holding this province and perhaps others back from using that?
It's difficult to get a license to prescribe Suboxone. Right now in Manitoba, the Suboxone license is tied in with having a methadone license. I have both, but getting a methadone license requires a lot of extra training. The Suboxone license usually takes about 6 hours, and that's it. There's also, communities have to be set up to dispense the Suboxone. It's a controlled medication, and there has to be some education in the communities. So those seem to be 2 of the major barriers.
You know, there are those who say insight locations, places where people can go and safely do their drugs and be monitored would help some of these issues. Is that the way you would view that?
In certain areas like downtown East Side Vancouver, where you have a number of users that are on the street that are using in unsafe conditions, I think that it's a great option. I don't see that would be the first option in remote communities. I may be wrong. I'd be interested in talking with community leaders about what they think about this.
Is there something for remote communities that could work?
As I said, the first thing I'd like to see is Suboxone treatment available for the communities. I'm also not aware if the communities have access to what's called naloxone, which is sort of the antidote for people that have acute opioid overdoses and are dying. So that could be something else that would be available for community members. But those would be the 2 first steps that I would like to see.
Dr. Simm, you have hundreds of patients. What's the success rate for people with these addictions, opioid addictions? What are the chances that they're going to get their lives back? With
people on opioid replacement therapy, methadone or Suboxone, general rule is about 1/3 will get way better, about 1/3 will get somewhat better, and 1/3 won't improve that much. Unfortunately, abstinence, Dennis, hasn't been a great success, and that's for anybody that's been trying to get off of these substances. They used to have something called the Narcotic Farm in Lexington, the United States at the Lexington Penitentiary. People would go there for years, and they'd have all sorts of rehab, but they'd relapse as soon as they got out. The relapse rate in Scandinavia is 90–95%, and the relapse rate in Canada without opioid replacement therapy is really high.
Is addiction something, you know, like you say, fentanyl is the latest blip, but is there just going to be something else that comes down the pipe? Is this going to be opioid addictions a concern that we have for years to come?
Well, in approximately 20 years I've been doing this, I've seen a number of worst drugs of all time: crystal methamphetamine, ecstasy, something called crank, crocodile bath salts, high-test marijuana, OxyContin, fentanyl. Something worse will come along.
Sad to think of the future, I guess.
It is.
Dr. Simm, thank you so much for taking the time to speak with us about such an important topic. Time to take another quick break, and then we'll be back with a look at next week's Face to Face.
If a story is uncomfortable, would you change it? No, you wouldn't, because there's no power in holding back. Stories have the power to change lives, so true storytellers uncover every side of hunger, of families, water, shelter, and health. So we're going to tell you our stories every day until issues transform, and our communities transform with them.
Welcome back to Face to Face. Our thanks to Dr. Jim Simm. Next week on the show, our guest will be Manitoba, Keewatin, Okimakanak Grand Chief Sheila North Wilson. We will tackle a range of issues. Here's a peek at some of our conversation. There have been some concerns raised about how things have gone so far with the inquiry. Do you share some of those concerns?
Absolutely. I think we need more communications and dialogue from the inquiry itself. I don't know what the issues are. Could be simply logistics and not enough communications expertise. I don't want to say that, exclusively, but I think that needs to be brought to another level, because our communities and our families deserve a lot more respect in that way, where they can see what the process is. They need a transparent system. And so if they're not feeling included now, that's going to be a problem. And with such a short time frame that this inquiry is given, this commission is given to do, it is concerning that it's not out there as much as it should be.
That's all for today's show. We're always looking for new guests, so if you have any suggestions, please email us at news@aptn.ca. Thank you for tuning in to Face to Face. I'm Dennis Ward. We'll see you next time.